Good morning, or evening, or whichever day of the week you happen to be in the world as we're listening to that. Welcome to this morning's Thyro multidisciplinary seminar. We've got a wonderful tumor board assembled from all over the country here this morning of different specialists with some cases presented by Dr. Tarasova from Moffitt Cancer Center. So let's get started, and I'll just go around the screen that we have here and let folks introduce themselves. Dr. Alexander, you're up on top.
I'm Erik Alexander. I'm an endocrinologist at the Brigham and Women's Hospital, Harvard Medical School in Boston.
Carrie Cunningham. I'm an endocrine surgeon, the section head at Massachusetts General Hospital across town from Erik.
Fantastic. Dr. Gauci.
Hello, I'm Richard Gauci. I'm an endocrinologist and nuclear medicine physician at Fiona Stanley in Perth, West Australia.
Fantastic. Dr. Khorsandi.
Neuroradiologist, Mount Sinai Icahn School of Medicine, New York.
Thanks, Azita. Dr. Brandwein-Weber.
Hi, Margaret Brandwein-Weber. I'm Chief of Pathology at Mount Sinai West, which is part of Mount Sinai Health System. I'm a head and neck pathologist and director of the Head and Neck Pathology Fellowship, and I work with Mark Erkin.
Oh, you poor thing. Okay, so you try to overcome that as best you can. Dr. Newbold.
Hi, I'm an oncologist at the Royal Marsden in London.
Fantastic. And Kate also does oncology over there, does radiation oncology and systemic therapy and oncology. You do all of that sort of stuff over there?
So we do radiation and systemic therapies and the radioiodine, yeah.
Oh, fantastic. Marvelous. I'm Mike Tuttle. I'm one of the endocrinologists at the Memorial Sloan Kettering Cancer Center, and I get the fun of moderating the tumor board, which basically means I don't do any work at all. I just listen to the cases and ask questions. It's a great job if you can get it. I highly recommend it. Dr. Tarasova, introduce yourself, and then let's get started on the cases.
I'm an endocrinologist. I practice in Florida, in Tampa, at Moffitt Cancer Center. My focus is in thyroid cancer, and I'm ready to start to present the cases.
Okay, Vivian, let's bring the first case up.
Vivian, you're always doing an awesome job, I gotta say.
Thank you.
I know we do the hard work. Dr. Tarasova, when you were thinking about cases to put together for the tumor board, what kind of cases were you thinking about, without the specifics of this case? You know, it was your job to kind of pull these together. So what were you kind of thinking about these?
So the reason why I selected some of the cases, because they're all my patients, and some of the cases were really challenging to manage. And this will be a great opportunity to get an expert opinion from all over the world to see if there are any other ideas, because sometimes it's not very straightforward how we manage thyroid cancer. Some of the cases have certain teaching points, and I think that it will be a great opportunity to discuss them with this with my colleagues.
Yeah, that's awesome. It's always fun to see how other people do things when we all get the same outcomes, but how we're sort of thinking through the cases. Okay, let's start with the first case. I think we're good to go.
So I don't have any disclosures for this presentation. And the first case, next slide, is a 30-year-old female who presented with thyroid nodules palpated by her GYN. She had ultrasound of the thyroid in August 2021, which showed enlarged thyroid gland measuring 6.9 by 2.7 by 2.1 centimeters on the right and 6 by 2.2 by 1.5 centimeters on the left. Isthmus was 0.12 centimeters. There were bilateral multiple thyroid nodules. Most of them are TR3 and TR4. On the right side, thyroid nodules were measuring up to 3.1, 2.1, 1.4, and 1.1 centimeters, and on the left up to 2.2 centimeters. For thyroid function tests at the time of the ultrasound or with the normal limits, the patient did not feel these nodules. There was no compressive symptoms, no symptoms of dysphagia, no dysphonia. The patient denies history of radiation exposure to the head and neck area. Family history was consistent with multinodular goiter, but no thyroid cancer was detected in the family. Her mother had history of skin, ovarian, and endometrial cancers, and she had two sisters that were healthy. Next slide.
So, pause for me right there. Richard, just from a very practical standpoint, she's got what I call lumpy, bumpy thyroid. There's a bunch of nodules in here that are 2 centimeters, 3 centimeters. You know, you can't biopsy all of them. I mean, how do you decide which ones you really want to biopsy, or any or all?
So I guess you look at them with their ultrasound characteristics, pick probably one on each side. So if you're looking at trying to do conservative surgery, you'd like to confirm that there's at least benign disease on one side of the gland. So I'd probably pick the dominant nodule on both the left and right and arrange an FNA, ultrasound guided FNA.
Carrie, should we just go to surgery? I mean, she's 30 years old. We're about to spend a whole bunch of money doing a great big workup. And at the end of the day, she's likely to come see you. You know, we got to watch this for years, or sort of, how are you thinking here, Carrie?
Yeah, I mean, I think the point about biopsying this, as we all know, that the microcarcinomas are the little ones, right? And what is the clinical relevance of taking those out, biopsying them, et cetera. So in this case, if all the nodules are looking relatively benign, I have a conversation with the patient. I will tell her she's young. It's highly likely she's going to wind up that most of these nodules, it's very unlikely that they're going to get any smaller than likely get bigger. Makes my job easier to take it out sooner than later, before it gets, below the sternum. And so, I would have a conversation with her. If she's really, possessive of her thyroid, then I could observe her for a while, but almost invariably these patients with the nodules this side wind up going to surgery. And if it is a lumpy, bumpy thyroid, as you call it, and it's a benign multinodular goiter, I would recommend that we take out both sides, given that the size of the nodules on both sides.
Erik, she's got a long family history of multinodular goiter. Most of these folks are very comfortable watching because their aunts and their cousins have had this. What makes you say, even if you don't have an abnormal biopsy, when do you start saying time to think about surgery, moving towards surgery over the years?
I mean, I think Carrie was hitting on it. I mean, the size of the gland is notable. I mean, a 7-centimeter longest dimension lobe is a pretty big, gland. So we kind of generally say that she has a goiter. And the extent of nodularities in a younger person, noting that young age is a risk factor for slightly increased risk of malignancy in nodules. So I couldn't agree more with what Carrie said, which is that nodules tend to grow over time, even if they're benign. She's young, she's healthy, she's got a big gland. She probably thinks she doesn't have symptoms, but if she removed it, she may actually feel a little bit better. So just some general thoughts, I guess, to start.
Yeah. So Kate, I really like Dr. Tarasova, but I don't trust her. So when she puts words on a slide that says mom has a history of ovarian and endometrial cancer, she's trying to trick us into something. But outside of her usual tricks, as an oncologist, when you see a patient, thyroid cancer, otherwise whatever, and mom has a couple of cancers or family history, but how should we be thinking about this from the oncology realm, hereditary sort of syndromes, Kate?
Yeah, I mean, we focus on this a lot more now because of the ability to test for a wider panel of genomic abnormalities and alterations. So because it's such a fast moving field, anyone with a history with kind of first degree relatives or with multiple relatives, I would actually refer to our cancer geneticist for a discussion. And more interestingly, we are picking up quite a lot just through this without necessarily very high degrees of suspicion in the first instance. So yes, I now refer to the cancer genetics team.
We do the same thing, especially ovarian, breast, endometrial, pancreas. There's so many syndromes out there. I don't even have to know which ones they are anymore. I just have to know how to check the box to say, go talk to my clinical folks. So, okay. All right, Valentina. So we've got 30-year-old. She's got multiple nodules that we're probably headed toward a biopsy. Show us the ultrasound and take us through a little bit more.
So next slide. Yes, this is the ultrasound. And as it was described in the report, there are multiple thyroid nodules that are mostly TR3 well demarcated without really evidence of extra thyroidal extension, not really highly suspicious based on their ultrasonography features, however, meet criteria based on size for biopsy. And therefore, she had biopsy of the 2 dominant nodules. Next slide. So the FNA biopsy of the right mid-thyroid nodule that was 3 centimeters, TR4 thyroid nodule come back as follicular lesion of undetermined significance, Bethesda category 3, and the left one, 1.5 TR4 thyroid nodule come back as benign, Bethesda category 2. So as the patient had
So Dr. Brandwein, help me with this category 3. Is this cancer? Is it not cancer? Is it a percentage?
Right. Well, now you do remember that I'm not a cytologist, right?
But you're closer to a cytologist than I am. So tag, you're it.
Okay, so it's undetermined potential, so it really could be anything, you know? I mean, it could be benign, could be nifty P, could be follicular carcinoma. So
It's in that box. Richard,
Yeah.
down under, how do you deal with this? Unmute there, Richard. There you go.
There we go. Typically, we'd offer patients a repeat biopsy, but as the previous speakers have alluded to, in a younger person with multinodular disease, they might opt for definitive treatment early rather than going through a surveillance program, which might involve lots of ultrasounds and lots of FNAs.
Yeah. And is in the United States, molecular testing is pretty commonly done in this setting. In Australia, is that available or not available, or how do you guys use that?
We wouldn't use molecular at this time point. In an older patient, we would repeat the FNA at 3 months.
Gotcha. And just follow them clinically. I mean, they'll declare themselves over time. If the patient really wants to know, we take it out, give the tissue to Dr. Brandwein, and she'll be very definitive. Valentina, there's unlimited resources in Florida. So what did you guys do?
So we send molecular markers on that Bethesda 3 nodule. Next slide, and that was the report.
Can I make one comment about the slide previous to that?
Thanks,
I
Mary.
love your diagrams. We do not have these at our hospital. We're not necessarily this case, but it is really critical that if you are doing biopsies and you're doing serial biopsies over time, to really document where you're taking the biopsies if there are bilateral nodules. So that is, I really like I just wanted to point that out, how important it is that if in 6 months or a year, a different cytologist, someone else is doing the FNA, to know specifically where it was biopsied before is really important. So I just wanted to, those are very nice reports you have there.
Yeah, and a challenge when you have multiple nodules that are all kind of similar looking, right? Did we really biopsy the same one? Well said. Good, Carrie. Okay, so Valentina, we ordered some testing, and all right, Dr. Alexander, Dr. Tarasova ordered the test and then sent the patient to Boston. How do you interpret this?
Yeah, so they used the ThyroSeq platform, which is one of the 2 really well-validated tests in the United States. And so this one came back with a mutation detected. There's different scenarios of molecular data we will get back. And you can see below that they detected mutations in PTEN. I think that's a unique one in the sense that that can be both somatic and rarely can be germline. And most of the data we get back genetically is dealing with somatic mutations unique to the tumor growing itself. But I think you'd want to step back and ask yourself that question. I guess it's notable there's 2 mutations in the same gene. So that also is something we fairly rarely see, I think.
Yeah. So Valentina, when you got this sort of PTEN result back, sort of what went through your head there, and how were you thinking about this?
So definitely there is a concern for PTEN hamartoma tumor syndrome, whether it could be germline-driven PTEN mutation, and that potentially can predispose the patient for multiple cancers and other abnormalities. I think as endocrinologists, that's actually, we have responsibility in terms of like early detection of this syndrome, because the first manifestation of PTEN hamartoma syndrome is frequently thyroid abnormality, and this could be just multinodular goiter, whether it will be translated to follicular thyroid cancer or not. But when we see that PTEN mutation, particularly with this high allelic frequency of 51%, definitely the clinical suspicion was high there was concern for possibility of germline mutation. So the patient was referred for genetic testing. And the next slide will show that actually that turned out to, before we did that, the patient elected to go with total thyroidectomy. Yes, the next slide. Yes, that would be the right thing. So, and the patient elected to go with total thyroidectomy because even though the risk of cancer is low, but it was still there, given her age, there was a discussion with the patient and she elected to proceed with surgery. And the pathology showed that there was follicular nodular disease in the setting of Cowden syndrome.
Okay, pause right there for me for a second, because my favorite thing to do is to make Margie read slides off a computer screen from across the world. Tell us a little bit about what we would expect to find in Cowden syndrome, Margie. Not surprised it's benign. If it was a thyroid cancer, what would it likely be?
Right. Well, you know what this reminds me of? This is like, I'm on the George Washington Bridge and like, Ippolito is sending me images to my cell phone saying, what on Frozen, what is it, So this is about on this level, which of course I love, right? So you can't see the architecture, you see prominent nodules. You do see some areas that are cellular, but cellular, but well circumscribed. So, please give my regards to Bruce. He's an awesome pathologist. You're very lucky to be working with him. I'm sure if Bruce says this is thyroid follicular nodular disease, that's what it is. I have not, to my knowledge, seen yet benign Cowden disease thyroid. So I can't really tell you if there's anything special in that. I think to my understanding is it just the benign disease is just multinodular goiter. Now, when we say multinodular goiter, it's one term, but in fact, some of them look more proliferative, while some of them look more degenerative, and we don't really parse that out. I can't tell you if there's any changes like that in Cowden's disease. So I would, just looking at this, I think worst case scenario, maybe there's NIFTY-P in here, but in this case, not. And what you can see here is if you in your mind's eye draw circles around the nodules, they all seem to be very well defined, and that's a helpful, finding at low power.
And then Valentina, you did obviously germline testing on her to see what was going on.
Yes, so we can advance to next slide, which actually another pathology report, as I was sent multiple slides, and that could actually better describe the Cowden's thyroid gland. We can advance to next slide. And indeed, she had genetic testing done, and it was pathogenic mutation consistent with Cowden syndrome or PTEN hamartoma syndrome. Therefore, the patient currently is undergoing different cancer screening, including endometrial cancer, breast cancer, colon cancer as well. Next slide. And that will also trigger the workup for her relatives, including her sisters and her mother, who is actually likely had Cowden syndrome as well. I put this slide in order to talk about manifestation of Cowden syndrome. And patients may be Cowden syndrome or PTEN hamartoma syndrome. There are actually a couple of syndromes within PTEN hamartoma syndrome. There are a couple of different syndromes with different clinical manifestation, including benign and Ravach-Lava-Riley syndrome, Proteus-like syndrome, as well as Cowden syndrome. But for endocrinologists, we're more used to Cowden syndrome name. And patients, the first manifestation is frequently multinodular goiter or thyroid cancer. There could be some acral keratosis, renal cell cancer, gastrointestinal hamartomas and cancer, endometrial cancer in women, testicular lipomatosis in men, as well as prostate cancer in men, or lipomas, breast cancer, breast papillomas, fibrocystic changes, as well as specific facial trichomomas and oral mucosal papillomas. Next slide. And I have quite a few patients with Cowden syndrome, and they all have this specific appearance of the skin, which is a little bit like lumpy, and we can see this the specific changes of the skin, as well as specific appearance of the lips and the arm, which has that cobblestone-like pattern, acral hyperkeratosis and palmar pits, small yellowish papules of the eyelids. So this is when we see patients, young patients with multinodular goiter with the rapidly progressive, with not necessarily rapidly progressive, but with multinodular goiter, typically TR4, TR3 nodules with these specific skin changes. This is something to think of. And
I think as Kate was mentioning before, I think we're picking up more of this. I think there's more Cowden syndrome than we're picking up. From a thyroid cancer standpoint, the times I always think about it is follicular thyroid cancer in a young people, you know, a teenager or a 20-year-old with a follicular thyroid cancer. That doesn't belong in those patients. Those are Cowden's, or follicular adenomas in those teenagers and 20-year-olds. So when they're coming in from us, that's how I always think about them. Any other comments from the panel about this? I thought was a great case, because if we're aware of this, and if you actually do a physical exam outside the thyroid, it's helpful. Other comments?
I'll just add.
Oh, go ahead.
I'll just add in, I mean, my experience with Cowden's, I agree, it's kind of out there smoldering a little bit. And what I find very unique about it compared to other germline illnesses is the diversity of the phenotype that exists, even within the dominant family kind of inheritance pattern. The child can have a different set of endpoints than the mother. And so you have to kind of be alert to the unusualness of that there are many benign findings and then this kind of smoldering malignancy risk.
Yeah, they do seem to all kind of have different ones, don't they, in the family? Kate?
Yeah, and just to emphasize that if you have a young patient with follicular thyroid cancer, always do this, because as Erik says, the phenotype can be very different and not particularly obvious, but just do it. And that we picked up many like that.
And many of that's the index case. We pick up the thyroid cancers and the follicular thyroid cancers and the teenagers and the young 20 years old, and that uncovers the entire family. So I agree.
Am I allowed to ask a question?
Okay.
So in this case, so let's think about it the other way. If you don't know about these other features, is there something about the cytology beyond the younger person with multinodular goiter that would push you to get genetic testing? Because we're not going to get genetic testing on every patient with multinodular goiter.
Any idea, Margie?
Well, you know, so the answer to your question is, to my knowledge, not. But I think that the skin findings are so easily accessible, you know, that you could push for goiter with skin findings. You know, I mean, that kind of lumpy bumpiness, that's really something. You know, I just want to make a comment about FAP, right? You know, we all know we all know that familial adenomatoid polyposis syndrome, right, is associated with an increased risk of thyroid cancer. And one of the phenotypes is this very specific type of like cribriform morula phenotype. But that's only one phenotype within the FAP syndrome. And although I've not seen it, I have read that you could have very typical looking PTCs in FAP. So, you know, we like to think about, oh, okay, this is like a very specific finding for this syndrome, but you could just have a run-of-the-mill cancer in a syndrome.
Absolutely. So I think take-home points on that one is the genetic syndromes and our ability to identify them has increased dramatically over the last 10 years. Very low threshold, really look at the family history. Multinodular goiter in young people, do a physical exam, that still works. These would all be signs that would like really flag it, right? So I think important for us to play a part in that. Okay, let's look at your second case, Dr. Tarasova. What do you got?
Next slide, please. All right, so the second case is a case of a 55-year-old female who presented with multinodular goiter. She has actually a history of the left dominant nodule that measured 3.6 centimeters in 2015. Back in 2015, she had a FNA biopsy of that nodule, and it showed nodular hyperplasia. Follicular neoplasm cannot be ruled out. Not sure which Bethesda category was to assign, but this was just the reports that we received from outside institution. That nodule was observed in 2016. It measured 3.7 centimeters, 2018, 3.8. In 2019, it was 4.2 centimeters, and there were other two small nodules on the other side, measuring 0.6 and 0.4 centimeters. They did not meet criteria for biopsy. Because the progression of the left thyroid nodule, she had FNA biopsy of that nodule, and it showed benign follicular cell with lymphocyte, possible lymphocytic thyroiditis. All these reports were from outside, and cytopathology was not reviewed at our institution. Because, next slide. Because of the growth of that left thyroid nodule, the patient, and because she did start to develop some symptoms, she decided to go with lobectomy. And surprisingly, pathology showed 4.5 centimeter medullary thyroid cancer without evidence of extrathyroidal expansion, no lymphatic invasion or vascular invasion. The tumor was completely resected and margins were negative.
Dr. Gauci, what the heck's going on here? We got a benign biopsy. We'll come to Dr. Brandwein-Weber and let her defend her people here in a few minutes, but a benign biopsy that turns out to be a 4.5 centimeter medullary with no lymph nodes. What's going on here?
So I've encountered this before. I think there is a few similarities between a follicular lesion and medullary thyroid cancer that can trick cytopathologists. It's unfortunate. It means the patient will need more extensive surgery. I'd look to stage the patient carefully. I'd do some biochemical markers, calcitonin and CEA. I'd probably, being a nuclear physician, do a PET scan. Of the PET traces available, I'd do F-DOPA locally. I find that's got the best sensitivity and specificity for medullary thyroid cancer. That would be my approach. And I'd refer the patient to genetic services and take a careful family history. But at 55, probably starting to lean towards a sporadic presentation.
Yeah, Erik, I'm used to seeing medullaries pop up in the Bethesda 3s and 4s, right? We pick them up occasionally on the molecular testing. Not so much in the Bethesda 2s. Any thoughts there?
I agree completely. I mean, I think the take home, it's not ever to say that the cytologist wasn't doing a good job, but there's always a value in a second set of eyes. And so most of us, whenever you get an outside referral, just refer those slides also to our own pathologist to take a look.
Margie?
Yeah,
Thoughts on that?
I've actually seen a case just like that where, the FNA was negative, and I told Mark, oh, it's I don't remember the size of it, medullary thyroid carcinoma, and he's like, how could it be? And in that case, it was, there were a lot of sort of microcarcinomas, and so I kind of put together an aggregate size of it, to say that it was whatever size I said it was. But, look, again, I'm not a cytologist, I didn't see it, but if it's a well-differentiated, cytologically well-differentiated medullary thyroid carcinoma, and the cytologist is not thinking about it, the round nuclei, I guess, people can think it's okay, it's follicular cells and that's it,
Carrie, a 4.5 centimeter medullary with no obvious lymph nodes. What are you sort of thinking about there in terms of staging or how you're going to sort of attack this?
I mean, we've covered everything else you do beforehand, and with my colleagues, calcitonin, CEA, I do my own ultrasound. I would be very, very, it's been a long time in the neck looking at the lateral necks. My colleagues in Europe this person would be getting in general would be getting a bilateral, lateral, central, contralateral lobe. Obviously, you want to do a laryngeal exam and make sure your vocal fold is functioning prior to taking this patient back to the surgery. But in general, this patient's going to get the kit and caboodle if there's any indication in the latter. Once the cat's out of the bag, as many of us know, we don't have great treatments, although I'm sure we'll probably discuss those in a few minutes. But in my estimation, if there's zero evidence of any lymphadenopathy, I would go back and do the contralateral lobe and do a very good job of doing a bilateral central compartment dissection.
Dr. Khorsandi, we don't have the calcitonins or CEAs or anything yet, but if I came to you and said, look, I'm worried there may be lymph nodes in the neck given the size of this medullary, there might be distant mets, what would be the sort of optimal imaging you guys would do at New York?
DOPA. I would go with the nuclear medicine PET using L-DOPA. You could do a CT of a neck, but the problem with medullary is I've seen 5 millimeter lymph node. They have no specific characteristics. It's not like PTC that you could see calcification, avid enhancement, cystic changes. So I would do a PET CT with L-DOPA, and that's your best bet. But I have to tell you my experience. I've seen cases, we call the neck nodes negative. The surgeons take the patient to the OR. The neck nodes are positive and we get yelled at. So we're very poor on imaging in telling you about the positive lymph nodes and medullary thyroid.
Richard, tell us. Oh,
I want to make a comment about the actual, when you see the lymph nodes, they are different. They look different than, that sounded familiar to me. When you see them grossly in the operating room, they look more like Hashimoto nodes than the papillary thyrocarcinoma nodes, which are clearly malignant. So I totally agree with that. They can be hiding, missing, tucked behind the nerve, etc. So very good clean out is very important for medullary.
awesome. Richard, we're all of us are used to FDG PET, and now you nuclear medicine guys throw this DOPA stuff around. Tell me what the heck that is, and when should we be thinking about it?
So it's imaging of the sort of neurosecretory granules. You can think of it as like an alternative MIBG. We use it sparingly. We use it for pheochromocytoma. We use it for medullary thyroid cancer. We use it in dementia imaging. There's a variety of other things that it's useful for, but as an endocrinologist, it's mainly looking at pheos and medullary thyroid cancer.
So it's just a different PET tracer that the PET scanner can see that localizes to more neuroendocrine as opposed to our FDG, which is the labeled glucose, right?
Yeah, so it's fluorine labeled, so it's F18 as well, just like FDG, but it's, instead of being labeled to glucose, it's labeled to DOPA.
All right, Dr. Tarasova, obviously we didn't have a pre-op calcitonin. So Carrie's already mentioned there, the making sure that we make sure the adrenals, we don't have a pheochromocytoma, that would need to be dealt with first. Evaluating for parathyroids is that sort of stuff, but we're now with a lobectomy. We don't have a pre-op calcitonin, so I guess you'll grab something post-op and see where we are. Okay, so let's keep going.
Yes, so this was a big surprise for everyone, that diagnosis of that medullary thyroid cancer. When she came to our center, she was already diagnosed with a medullary thyroid cancer and came for further management. We obtained family history, and her brother had recurrent kidney stones, but there was no family history of medullary thyroid cancer or pheochromocytoma. Next slide. 5 weeks after surgery, her calcitonin was undetectable, but her CAA was 77.5. Her calcium PTH was within normal limits.
Okay, hold right there for me for a second. Kate, we don't know what the pre-op calcitonin was, but it must have been sky high with a 4.5 centimeter medullary. That CEA at 5 weeks of 77, CEA is obviously a marker of medullary as well. You worried about that? That's going to go away over time. So what do you think about that?
I am a bit worried about it. It is, however, still quite early days post-op at 5 weeks. And so I would repeat it again, probably another 6 to 8 weeks after that, just to see where it's going. Quite rightly, I would also image the rest of the body, which has happened at that stage. And the other thing that we would do just to bank the information for future, should we need it, is to do a somatic RET on the pathology as well.
And tell us what you're looking at, because we're going to do germline to make sure he's not an MEN2. Tell us about the somatic. What are you looking for in the tumor itself, Kate?
So we're looking for a somatic RET now because we have RET specific or RET directed therapies. And we know that from the early data, these are very effective and appear to be very well tolerated, and it gives us an additional potential systemic therapy should we need it. Up till now, we only have multi-kinase inhibitors of vandetanib and cabozantinib, which have shown a progression-free survival. Also for cabozantinib of a benefit of 7 months over placebo in progression-free survival. So we have been looking for other options, and the RET-directed therapies are important. If you do it now on the path, you've got that information, which may it may influence your management decisions down the line if you know you've got that banked. We may not need it, but it's just useful to get it at this point when you've got your hands on the path. The CEA, just to say, is not always specific for medullary thyroid cancer, and we have been caught out a couple of times with coexistent colorectal cancers. And so, you know, obviously the probabilities are it's related to the medullary, but just always just keep a bit of an open mind if you've got an unexpected raised CEA when everything else would suggest that things are under control from the medullary point of view.
It's always been puzzling to me because in colon cancer, the CEAs are back to normal in 4 to 6 weeks. But in medullary, it takes them 2 or 3 months to get back to normal. The calcitonin has a half-life of minutes. It goes away within just a few days. And I still don't understand. It's got to be more than just a half-life. There's something else going on here. I don't know whether it's stimulated or something else going on, but we'll routinely see the calcitonins drop away in a week or two, and the CEAs take 3 or 4 months to go away. So interesting. All right, keep going, Valentina.
So at that time, when we saw her, we obtained ultrasound of the neck for lymph node mapping. There were no highly suspicious lymph nodes. There was not actually even something that could be considered for biopsy. CT of the neck with contrast, no suspicious lymph nodes as well. CT of the thorax, abdomen, and pelvis with 3-phase contrast showed like CT of the lungs showed scattered pulmonary nodules, small, all sub-centimeter. There was 6.5 centimeter hepatic hemangioma, calcified splenic granuloma, adnexal cyst, and a kidney stone on this anatomic imaging studies. So based on all that, the patient was referred to, based on elevated CA and the newly diagnosed adnexal cyst, she was referred to GYN. We also referred her to, she was due for colonoscopy, that was done as well. Next slide. So the patient, by this time, the results of the germline testing come back, and it was negative. And then her calcitonin and CA had decreased to undetectable levels because we were waiting. The decision was taken to proceed with to do completion surgery with neck dissection. However, we waited for 90 days for that to happen. And in the meanwhile, we were following her tumor markers, and they all came back normal. So,
Margie, let me ask you, because I get a benefit out of this too. Anecdotally, it feels to me like there's some of these medullaries that get to be 4 or 5 centimeters. They're almost encapsulated. They have no lymph node metastasis, and they do remarkably well. That's just anecdotal. We've never studied that, but it seems like there's a separate group of those. Have you seen those bigger ones with no lymph node metastasis? Do they look any different to you? Can you remember?
Yeah. Well, you know, I'll tell you, some of them can look, you know, hard, you know, either totally encapsulated, non-invasive, or just with minimally invasive. And so little, if you're not thinking about it, you know, you might think it's something benign. You know, we've never looked at the outcome of our medullary thyroid carcinomas, but, you know, there's a wide range. You know, we used to say that medullary thyroid carcinoma is like the melanoma of the thyroid, right? It can look so varied. So, yeah, I have seen, you know, follicular adenoma type medullary thyroid carcinomas.
Yeah. Yeah. And I mean, they have sky high. I mean, some of these, last one I saw had a pre-op calcitonin of 8,000.
Right, because they're well differentiated. They're doing what they're supposed to do.
Yeah. Carrie, any feel for that? I mean, you see a lot of medullary and you've got registries and things. Any feel for that?
I mean, I'm biased because there's usually always lymph nodes for someone to come back and see me. But I quite honestly, I have not. I haven't seen this where it's that big. When I see something that big for a medullary, different from a PTC in terms of potential for metastasis, et cetera, you know, not necessarily correlated with size. With medullary, I am very highly suspicious, but obviously other people have had a different experience. It's interesting to hear.
I agree with you. I think 99% of the time it's 4.5 centimeters. They better have lymph nodes. If the report says no, I go back and relook at the images and all that stuff again. Let me push back here a little bit, Carrie. I know the automatic thing is going to be to do a completion and central neck dissection. What if I say no? It's a sporadic. We've already got a calcitonin that's undetectable. What's the benefit of completion and I assume ipsilateral central neck dissection at this point. Is there any room to push back on that at all?
Sure. You're in control of your own thyroid gland. And I would have that conversation. I think it's more if we're weighing risk and benefit, right? So the risk of missing something is, in this case, different from well-differentiated thyroid cancers. The risk of missing something, I get, we have better targeted therapies now. However, from my practice, that, you know, once you have a lymph node, once you have a calcitonin that's creeping up and you have metastasis, it's a lot harder to control. So I think, yes, we could follow them very, very, very closely. That being said, I would just impress upon them that this is something that is really best locally treated with surgery.
Yeah, if you can cure them, that's good. Because even in the sporadics, they're multifocal 20% of the time. They're bilateral 5% of the time. Kate, is this automatic completion thyroidectomy and neck dissection in London?
Yes, we would complete in central. What is much more debated now are lateral necks, whereas I think Carrie was suggesting that we might whip out the lateral neck nodes as well. But I think we are more conservative on that front now, rightly. So I think.
Yeah, and Erik, same way, completion and central neck.
I would agree.
All right. Well, don't tell anybody, because I've got several of these that I'm following with just lobectomy alone. We really need to go back and look at that. I think the strongest point is Carrie's point is your only chance to cure a medullary is before it leaves the thyroid. So if we watch these and they pop up something in a lymph node, we may have missed that chance. On the other hand, it's unlikely to kill them. To be honest with you, most of them I have with following, they had their first ipsilateral nerve damaged with the gland when it was taken out. So that changed the equation. But I think even Henning-Drawley and the guys are starting to have a second thought about how aggressive this automatic total and central neck dissection. Well, I think it's still what everybody would say right now. I wouldn't be surprised if we see that a little bit moderated over the years to come. Valentina, what'd you do for this young man?
So there was discussion, and there were the tumor board's discussion on that case, and the decision was taken to proceed, next slide, with the total completion thyroidectomy with bilateral central neck dissection, and there was no cancer, medullary thyroid cancer in the remaining lobe, and the 5 resected lymph nodes was negative for medullary thyroid cancer. And next slide. I was following this patient for 3 years after surgery, and she has excellent response to therapy. Her calcitonin and CA remain undetectable. Ultrasound of the nerve did not show any suspicious thyroid bed nodules. I'm keeping an eye on that hemangioma on the liver and the pulmonary nodules, but all of them remain stable.
That's awesome. Yeah, the one difference that we love the excellent response to therapy, and in papillary cancer, the risk of recurrence is about 1 or 2% with an excellent response. In medullary, it's closer to 10%. Because remember, in calcitonin, we can't measure less than 5 or less than 2, and there's these little small lymph nodes. So while it's very, very reassuring, it's not that same really, really low risk that we see in the papillaries and follicular thyroid cancers. Any other last comments or teaching points about this one? This is a great case to kind of walk through. Perfect. All right. Let's see case number 3, Dr. Tarasova.
Case number 3 is
14 minutes, so you got to get us through this one.
All right, so that's a very complicated case and not traditional, the case that's been managed traditionally. So this gentleman is 75 years old, and he has metastatic papillary thyroid cancer to the lungs. But back in 2008, when he was 60, he was diagnosed with thyroid nodules. And the FNA biopsy of these thyroid nodules revealed some fibroadipose tissue, so there was no really definitive diagnosis of malignancy. He was 5 years after that, in preparation of CABG, he was found to have multiple pulmonary lung nodules that were measured up to 1 centimeter. At that time, they did the biopsy of the lung nodules, and there was no evidence of malignancy. He proceeded with CABG in 2014, and at this time he had lung nodule biopsy done, and that was metastatic thyroid cancer. At that time, he was approached with the total thyroidectomy, but he declined to have surgery done at that time. He came back, he lost follow-up for some time, and then he came back in 2019 after his primary care did a funny biopsy of the left thyroid nodule, and that was positive for papillary thyroid cancer as well. At that time, his TSH was within normal range, his thyroglobulin level was 23, and he had positive thyroglobulin antibodies at 52. Next slide. So this is his ultrasound of the thyroid back in March 2019, and 6 months after, 5 months after in August 2019. So these nodules were highly suspicious. They were measuring 2.7 centimeters on the right and 2.6 centimeters on the left. The 5 months rather short-term follow-up with the ultrasound of the neck showed that there was concern for the progression of the right thyroid nodule that had, based on ultrasonographic features, had increased from 2.75 centimeters by 1 centimeter in 5 months. At this time, there was concern about progression in the neck. Next slide. This is the anatomical images, CT scan of the neck with contrast, and even based on the CT criteria, there was not as significant progression, but there was still concern that the left the left thyroid nodule is growing. The
Hold on
patient
just a second. Hold on just a second, Valentina. In the spirit of punishing people, if I can have Dr. Brandwein read slides from across the world. Azita, what are you seeing on this? Help me understand what we're looking at here.
So just for the sake of time, so the lesion involving the left lobe has become more necrotic. Size is difficult, in the slides to just assess, but on ultrasound, the left lobe got larger. In the matter of 5 months, it's centrally necrotic, which if it's the same imaging, it's really of concern. The right lobe, honestly, I'm not as concerned. On the ultrasound, it did look like it got larger, but most of that was shadowing because of the chunky calcification. The chunky calcification in the right lobe also got enlarged, but it doesn't concern me as much as that central area of necrosis involving the left lobe.
Go ahead, Valentina.
Next slide. So because of the concern of the local progression of the thyroid nodules and with the goal of local regional disease control, the decision was taken to proceed with external beam radiation therapy to the thyroid, and he was treated with basically 6,600 grays to the gross disease in the thyroid glands.
Okay, hold for just a second. We didn't go to surgery because it was not resectable or because he didn't want it, or?
Initially, he did not want it. And in 2019, he was not a surgical candidate. He saw about 3 thyroid surgeons, and he was considered not a surgical candidate because of poor cardiovascular state. At this time, he was already on some oxygen.
So Kate, not surgically resectable, gross disease, at least in this left lobe, external beam radiation. This looks like sort of the typical dose. Is it going to work? Is it not going to work? What are you thinking here?
So you're not going to cure this patient with external beam radiotherapy. So I think you then have to think carefully about what you're trying to achieve with what you're giving. I must admit, we would tend in that situation to only use external beam radiotherapy. Therefore, if we think they're going to be symptomatic or are symptomatic for control, and we would probably usually use a palliative dose in that setting rather than put the patient through the toxicity of a radical dose. However, they're not very radiosensitive. So if we would use 30 gray and 10 here, you're using 66 gray, which is a radical dose. So between 60 and 70 gray over 6 to 7 weeks is a radical dose. And we say radical when we're kind of aiming for more of a curative intent, which it will give as good a control locally as possible. So, but it will come with morbidity of acute toxicities during the radiation and xerostomia, dry throat, ongoing chronically. But it's yes, you fall into 2 camps in this situation. But I think you always have to question what you're trying to achieve.
Carrie, this decision that somebody's not operable, or I mean, can you what are you sort of thinking about this situation? I mean, it seems like radiation is a very suboptimal way to control this. So how do you think about this when you're faced with this, Carrie?
Yeah, I mean, this is obviously it sounds like the patient had very, his risk score from having general anesthesia is very high. I would actually, in this case, probably get palliative care involved. I think more and more, discussing with the patient his quality of life, having radiation to the head and neck, as we all know, is quite morbid for people. So I would just get them involved, really talk about their quality of life moving forward. You didn't expect this from a surgeon, I don't think, but I would definitely, I can't remember. I didn't hear if you guys did a bronchoscopy to see whether or not it was invading the trachea. I would probably do that as well. That would be part of the decision. But if the patient is going to be at high risk for surgery, I'm not scared of doing that. I would just have a very frank conversation with the family about the risk of surgery and maybe causing some of the difficulty with breathing. So I don't know if I answered the question very well, but I would have a very prolonged discussion with the family and potentially involve palliative care in the situation.
I think you did, Carrie, because I mean, you're not a candidate for surgery. That doesn't automatically make you a candidate for 6 weeks of external beam radiation, right? I mean, there's a lot of stuff that goes on with that. So I think having that third option of, are we going to do anything? Erik, what are you thinking about this one so far?
No, I would agree. I mean, I think, if you also were to advance 4 years and you're kind of in 2023, and again, this patient may not be a candidate, but this idea of also neoadjuvant TKI therapy to reduce the sheer burden can sometimes make people a much better operative candidate. And he or she may not be also amenable to that type of therapy. There are side effects, but it's worth just noting that as kind of a new paradigm that's developing.
And Richard, is this somebody you guys would be thinking about doing molecular testing on, or in that sort of setting here?
Yeah, so whenever we're presented with a patient with distant mets, we will get next generation sequencing using our TrueSight Oncology 500, and that will often give us targets for redifferentiation or systemic treatment options. We've also got very brave endocrine surgeons that sometimes rescue patients from amiodarone-induced thyrotoxicosis with heart failure. So when medical management's failing, so we would lean on the right people locally to see if, and also if we could perform surgery on this patient before going to external beam, and then using, if we can't do surgery or local treatment, some sort of neoadjuvant systemic treatment option.
So I'm going to pause this case discussion right here. Kate, let me come to you. Everybody's talking about this neoadjuvant. Can you tell me what that word neoadjuvant means and sort of how you're reading how that's going to be helping us in thyroid cancer here?
The neoadjuvant is a term for anything that just comes before, so treatment that comes before the definitive management. So in this situation, we're talking about surgery as being the definitive, the only option for curative outcome in a patient with localized disease, for example. And so neoadjuvant is anything that comes before that, as an adjuvant is obviously after that treatment. Concomitant, we're using drugs alongside radiotherapy. So that's where we are. And it is a paradigm shift, exactly as Erik said, that in thyroid cancer, we are beginning to get some interesting data coming through in medullary, in differentiated thyroid cancers, and obviously anaplastic, with using systemic therapies upfront to reduce disease volume and burden, to make something perhaps more surgically resectable, and giving better local control and hopefully survival rates.
Yeah. And Valentina, what sort of targets are you looking for if we're, in a case like this, not the medullary, but in the non-medullary? What are the sort of targets thing that would make you sort of potentially say there's a targeted neoadjuvant therapy there?
So we actually have the next slide. We actually have the molecular markers for the patient, and that was turned out positive for BRAF V600E and TOR mutation, so which made him eligible for combination of the BRAF and EPINEP when it became available.
Yeah. And so we go from there. Your read on this neoadjuvant sort of stuff, Valentina? I mean, we tend to get excited about stuff, and I'm never really sure if it's working as well as what we think, because sometimes it's targeted therapy. Other times it's just Lenvima, right? Anti-angiogenic. We can do neoadjuvant to try to shrink stuff. I'm struggling to know whether you take something that's unresectable, put them on one of these drugs, and still have unresectable but smaller, versus when it shrinks enough to make a difference. So you're sort of gestalt and read on that literature right now, Valentina?
Yes, I mean, in this again particular case, the selection of the systemic therapy was driven by his comorbidities and side effect profile of the medications, and definitely we need to know more about really efficacy of the different the choice of the systemic agents, particularly in the patient with the RAFI600T mutation that has differentiated thyroid cancer, which looks like a little bit different than anaplastic thyroid cancer, which has much more robust response.
Carrie, what are we really dealing with now? With this mutation, with that ugliness on the CT scan, what do you think we're treating here?
I don't know if you just saw my comment, but I actually have a very unfortunate, very young patient who has BRAF TERT tracheal invasion, almost very alike this case, no lymph node positivity. I actually did clear it out the whole neck because the original diagnosis was diffuse sclerosing variant of PTC. Key to re-review the slides carefully, all the slides, and our pathologist here diagnosed the patient as an anaplastic thyroid carcinoma. So that then, you know, in terms of surgery, and it may have changed, as we know, from an aggressive PTC to anaplastic in the time frame that we're talking about. So
it was the warning flag Dr. Khorsandi gave us from looking at that CT scan. Okay, Vivian, let's take down the slides. There was one question that came up, Carrie, that said everybody was doing, in the medullary case, wanting to do the central neck dissection. Was that based on the post-op calcitonin, the size of the nodule, or just any medullary is going to get you a completion in central neck?
In my hands, everyone, size really of the tumor. Not in this case, but in very small medullaries, you can get some tumors that do not secrete calcitonin. Very, very rare, but they do exist. But primarily the size in this case would make me the most concerned.
So the default's going to be completion and central neck, unless there's some exception, regardless of size or post-op calcitonin.
Yeah,
Okay,
even
good.
if the patient has distant metastasis. Just wanted to mention that, right? Because they still have local invasion pain also as well. Their lymph node metastasis seem to be painful to them. I'm sure you've all seen that, which is different from the papillary patients.
I thought I was the only one that was crazy that way. Yeah, I don't know why, but they hurt, right? We've occasionally had to take out lymph node metastasis because they were painful. And I just never see that in papillary. Anyway, so we're right at the hour. Dr. Tarasova, thank you for bringing us different cases to think about. It was wonderful today. Thank you for our international panelists. You guys did a great job. I'll invite everybody to come back next week. The next one is Dr. K-Paul Patel from NYU. Is going to be doing the year in surgical science. So we'll see everybody back in about a week. Thanks, team. Bye-bye.
Thank you.